it's one of these things you don't have to be very good at to enjoy. And it's like Nike, just say, just do it. Just don't worry too much. Just do it. It's good for you. And please don't judge your performance or past performances. Also, the onset of sexual dysfunction signposts high cardiovascular risk in men with or without diabetes. In women with diabetes, sexual dysfunction would be the first sign of underlying depression. And for both sexes, this is the paradox, it may arise from drug treatment of depression. So the illness can cause it, or the drug treatment of illness can cause it, which is unfortunate. But for UK men and women aged 50 plus years without baseline diabetes, marriage was associated with a lower HbA1c, and HbA1c rising, this from UK Biobank, was associated with an increased risk of divorce. In the USA, men who were divorced or separated, and women who were widowed, were at higher risk of diabetes-related mortality, and especially so amongst ethnic minorities. So antihypertensive drugs and sexual function. So ED is twice as common in hypertensive men and in normotensives, even accounting for other confounders such as age, smoking, diabetes, and essentially your vascular system is vasoconstricted. Men with ED are around 40% more likely to have hypertension, but also ED may be exacerbated by many older antihypertensive drugs, especially diuretics, beta blockers, and calcium channel blockers. In addition, spironolactone, although wonderful for primary hyperaldosteronism, because it also blocks testosterone, the androgen receptor, and to a lesser extent, testosterone secretion itself, is associated with hypogonadal features such as gynecomastia or reduced libido. Also, diuretics are often prescribed for calcium channel blocker-induced edema, even though it doesn't really work for that. And so there's potential dual impact on ED. But obviously, undertreated heart failure is also not great for the sexual function. So the preferred drugs will be vasodilators, so ACE inhibitors or ARBs, or alpha blockers. If you vasodilate, you increase the plasma volume, you increase the peripheral blood flow, may improve ED in many cases. But of course, this is a static. ED is in the small print of almost all drugs. And what really increases the risk of ED is if your physician tells you it's a side effect. And so this is the hard bit. It's probably best not to mention it to your patients because you will increase the risk of them experiencing that as a side effect. As long as you document that in the notes and reasoning, that no one will criticize you for that. So the other issue is how to identify men with hypogonadism in diabetes clinics. Remember, men with primary testicular failure, whether compensated or overt, ILH. Having high LH trebles your risk of having type 2 diabetes. And so one would expect, and that's even your diabetes clinics, to be enriched with men with primary testicular failure. Really easy to diagnose, ILH, low testosterone, and even more so in your CKD clinics. So these men may have low libido or ED refractory to first-line therapy with Viagra and other drugs. They may also have non-sexual symptoms, flushing, sweating, or painful gynecomastia. And this is the really easy, low-hanging fruit. If you see a normocytic anemia, check for hypogonadism there. You're more likely to get a pickup for primary testicular failure in a diabetes clinic with checking LH testosterone than you are with checking a serum ferritin. Well, the serum ferritin may help you identify those with hemochromatosis. Thinking about history of fragility fractures, cancer treatments, opiates for men. When I first started off, you had to be dying of cancer to get opiates. Now you have a bit of back pain, have a stick on a fentanyl patch. And also think about pain's very prominent amongst your post-pancreatitis patients with type 3C diabetes. And some of them will be on opiates as well. Do your fasted Nanian blood for LH, FSH, testosterone, and SMTG, plus or minus prolactin. You can always expand it later and do some add-ons. But if hypogonadism is excluded, Viagra is very cheap, very safe, have as much as you want. So how we classify hypogonadism? Primary testicular failure, your light bulbs are broken. Hypogonadotrophic or central hypogonadism is the light switch turned off. And I sometimes demonstrate that to my patients in clinic. Nothing wrong with your testes, the power's off. First one, very easy to diagnose, high LH, even higher FSH levels. Biological fertility, very hard to achieve, although there is increasing experience with microTZ. Secondary, LH and FSH levels are low or inappropriately normal, And that can be hard to distinguish from non-gonadal illness or venipuncture done at the wrong time, after lunch and afternoon. But you can restore fertility potentially with gonadotrophin treatment. There's been talk about late onset hypogonadism and obesity, and really the decline in testosterone with age, we now know from EMAS study and also the Chinese equivalent, SPEC China, that actually this is driven by comorbidities, particularly obesity. There is, in relation to low LH hypogonadism, no relationship with chronological age once you adjust for all the other risk factors. And so let's have a look at this quadrant. So these ones, primary hypogonadism, well, yeah, top left, primary hypogonadism, very easy to diagnose. Bottom right, normal LH, normal T, normal, easy to diagnose. Bottom left, men who are said to be secondary hypogonadism, but that's just based really on blood test results. In fact, although maybe 12% may have blood test criteria that fit with that, in fact, look at those men who have relevant symptoms, that's down to only about 2.2%. And in the top right, these are men with